So good evening. I'm Steve Rasmussen. I'm a psychiatrist and currently the chair of psychiatry at Brown University. And I have been working in the field of obsessive compulsive disorder for the last close to 40 years. Prior to coming to Rhode Island, I was 2 years in the Northeast Kingdom of Vermont, where my interest in OCD began. And since that time, most of my work has been devoted to trying to understand more about the causes and the treatment of obsessive compulsive disorder. And this evening, I want to talk a little bit about a research project that is a $2.5 million research project funded by the National Institute of Health that our team of researchers at Butler Hospital and at Brown is working on related to OCD. Now, this topic might seem a little bit not directly related to what might benefit you immediately. But one of the things I wanted to talk about with you tonight is the importance of being able to do research in order to develop new treatments. When I first started out, the only treatment that was really available for obsessive compulsive disorder was psychodynamic psychotherapy. There were no drugs. And behavior therapy, which had begun in England in the 1970s, had not made its way really to the US. And it's only through research that those treatments that are available today that help the majority of people with obsessive compulsive disorder, the serotonin reuptake inhibitors and exposure with response prevention, those treatments were researched and studied partially by our group in the 1980s and the 1990s. Now, in order to develop the next generation of new treatments, and I'm frequently asked the question of, well, are there any new drugs? Are there any new treatments for OCD? And one of the things that people have a difficult time understanding, I think, is that it's usually a 20-year period between the time that a new treatment is thought up and tested till it actually comes to market and is disseminated among people who might be treating obsessive compulsive disorder in many different sites clinically across the country. Patients like yourself have contributed greatly to our expansion of knowledge in OCD over the course of the last 3 decades here at Brown and at Butler Hospital. We were involved in all of the original trials of the SRIs for which patients volunteered, these double-blind trials. We've been involved in looking at issues of how behavior therapy can complement pharmacologic trials. And more recently, we've been involved in developing new innovative circuit-based treatments for obsessive compulsive disorder. I know that each of you knows what it's like to have this condition and that you are interested in trying to help others not have to go through what you have gone through in your own lifetimes. So your participation and interest in furthering our boundaries of knowledge about OCD is greatly appreciated. And I wanted to give you a little bit of an example from in the trenches of how a study gets conceptualized and then funded at the NIH and then implemented with your help. So tonight's topic really focuses on harm avoidance and incompleteness. And you might say, well, why doesn't it focus on obsessive compulsive disorder? And the reason for this is that our field is now undergoing a revolution where we are beginning to try to be able to understand patients' symptoms rather than diagnoses and the biologic basis of those symptoms. So we're interested in how obsessions form or how compulsions form. What's the brain basis of these two types of symptoms? And it's important in order to be able to develop new treatments to understand what causes them so that we can then think about how we can develop either new pharmacologic or behavioral treatments that will improve the condition. One of the things that's been noticed is that OCD very often is comorbid with other types of psychiatric conditions. There's a reason for that. We know, for example, that many of the genes that are involved in these disorders are shared across disorders, so that people who have panic disorder and other types of anxiety symptoms like social phobia and depressive disorders share not only symptoms, but also share the biologic basis for those symptoms. And so therefore, the National Institute of Mental Health has been very interested in trying to understand symptoms that go across disorders. And back in the early 1990s, Dr. Eisen and I developed a set of concepts called the core features of OCD. And in this, what we're talking about is that OCD may not be a single disease or a single syndrome. Just like if you have problems with your kidney, there may be 30 different causes of disease that affect the kidney. And in a similar way, when you have obsessive compulsive disorder, there potentially are many different causes of obsessive compulsive disorder. And trying to understand what we call the heterogeneity of the illness, why some people develop checking and some people develop symmetry rituals and others might develop contamination. Those things might give us clues to how to develop better treatments for those specific subtypes of illnesses. And therefore, we are very interested in thinking about symptoms. So one of the common ways of thinking about this in obsessive compulsive disorder is the major subtypes of obsessive compulsive disorder, which many of you are familiar with. Patients with hand washing and contamination fears perhaps form the largest subgroup of these conditions. Patients with checking rituals and worries that they're going to be responsible for something terrible happening. Patients with what we call taboo obsessions, or fears that they might harm someone else or do something to them sexually, or have religious obsessions, form another group. Patients who have symmetry obsessions or concerns about their health form other types of symptom subtypes of OCD. And for several years, we were very interested in trying to understand how treatment affected these different subtypes. And what we have discovered is that hoarding, for example, which used to be thought of as part of obsessive compulsive disorder rather than as a separate disease, which is now thought to be separate, did not respond as well to the serotonin reuptake inhibitors or did not respond in quite the same way to behavior therapy as other subtypes. What did seem to respond well to these two types of treatments were many of the other subtypes that could be grouped under a category of having avoidant tendencies associated with fear that something terrible was going to happen. These make up about 80% of patients with obsessive compulsive disorder, this what we would call harm avoidant subtypes. So most of the contamination fear, patients with contamination fears, most of the patients with checking rituals, most of the patients with somatic obsessions, they're all worried about what if, and how can I be sure nothing terrible is going to happen? They also tend to be worried about catastrophic things happening. If there's a 1 in a million chance that something catastrophic could happen, it's important to either avoid the situation or do rituals to prevent it from happening. So we find that this harm avoidance crosses different obsessive compulsive subtypes. And the reason that we're interested in studying it is because we know a lot about how fear and anxiety work in the brain. And so if we can begin to understand more about how it works in obsessive compulsive disorder and other disorders like panic disorder or like social phobia, which also have harm avoidant tendencies, then we may be more successful at developing treatments. Perhaps lesser known is the core feature of obsessive compulsive disorder called incompleteness. Although many patients now are more familiar with this term, it was first coined by Pierre Genet in 1903, who wrote the opus, the real textbook on obsessive compulsive disorder, which is probably the best written book on OCD that's ever been written. And he termed incompleteness as a wish to be able to finish an action or a thought completely so that the person felt that they could move on to the next thing that they were going to do, the next task that they had. And many of the patients that he saw with obsessive compulsive disorder suffered from what would be termed incompleteness. Oftentimes, this subtype is associated with patients who suffer from what we call maladaptive perfectionism. So examples might be the patient who needed to comb his or part his hair exactly in the middle. And because he was having difficulty making it symmetrical on both sides, it would take him 2 or 3 hours until he felt comfortable enough that it was parted exactly down the middle to go on to the next thing. Or the patient who felt that he needed to be able to buy the exact right tire. And so he would start to go and search it out on the internet. And the problem was that he just didn't search 2 sites. He would search 50 or 100 sites looking for the best deal, the best tire. He'd research all the aspects of, which tire had which characteristics. He then calculated how much money it would cost to go to that dealership. And he would spend hours on this and never make it to buy the tires, so that a year later, his tires were in the same condition as they were when he first started. or the patient who worried about having his car seat exactly in the right position, and would move his car seat up and down, which was electric in a relatively expensive car, to the point where it broke the electric mechanism. Again, he would spend hours doing this and neglect kind of what he was supposed to be doing the rest of the day. So these patients tend to get stuck on what many of us would consider routine motor actions or routine thoughts, and are unable to shake them. Now, why did these two subtypes interest us so much? Well, the reason is because what we have learned through experience is the patients who have the incompleteness obsessions and compulsions tend to not respond as well to behavior therapy, and tend to not respond as well to the serotonin reuptake inhibitors as the harm avoidant subtype. So we suspect that they may have a different underlying biology, a different underlying cause of the problem, and therefore we need to understand how each of these core features relate to each other, and how, in fact, the brain basis of these two disorders differ. So as a way of trying to understand this, and let me back up just a little bit more. So interestingly, one of the things that you can differentiate these subtypes on are the patients when they're small. So the patients with harm avoidance tend to be the ones who are very shy, who tend to perhaps have separation anxiety as a youngster, tend to avoid doing dangerous things, are worried about going to sleep at night. And in contrast, the patients with incompleteness when they're small children tend to be the ones that want to line everything up alphabetically, and tend to be the ones that are very rule bound. They follow rules exceptionally well, actually, and who tend to be hypersensitive to criticism and perfectionists. Also, they differ in the types of other comorbid disorders that they have. So the patients with harm avoidance tend to have comorbid panic disorder and comorbid social phobia, other types of anxiety disorders that have avoidance as one of their major symptoms, as opposed to the patients with incompleteness, who are more likely to have things like obsessive compulsive personality disorder, or tics, or hoarding. Now, back in the early 90s, when we didn't have very much information about anything about OCD in the brain, Lou Baxter, who was one of the first people to image OCD brains, patients with OCD, came up with this idea that the different types of connections between areas of the brain that were thought to be involved in OCD, the front part of the brain called the frontal lobes, and deeper parts of the brain called the basal ganglia and the thalamus, that there might be different parts of these loops that connected those structures that were affected in patients with tics versus patients who had more traditional checking and avoidant tendencies. And we've kind of extended this idea in our current research project, where we have begun to look at the MRI images, the functional MRI images of patients with harm avoidance and incompleteness. So what do you have to do to be able to actually implement one of these studies? And why does it cost $2.5 million to study something that sounds like most clinicians have a pretty good idea of what we're talking about? So first of all, in order to be able to really get definitive results about how these groups differ, you need a lot of patients. And so our current study has 200 patients with OCD who are enrolled, who we follow up over a 2-year period with multiple types of assessments, 2 or 3 hours. And I'm not telling you to dissuade you from participating in research, that it's 2 or 3 hours of questionnaires. These are all questionnaires of what you're familiar with, of things about what you tend to avoid and what things you tend to want to be perfectionistic about, and what different diagnoses you might have experienced in the past, what types of medicines you're on. So they're pretty routine questions. And then we ask people to do a variety of different cognitive or computer-based tasks that we distinguish people who have avoidant tendencies from those who are perfectionistic or suffer from incompleteness. So things like, how easily do you startle? You'd think might be more likely to occur in the group that have avoidant tendencies. And things like how you're able to distinguish the forest from the trees, and be able to engage in goal-directed behavior. Those are things that the incompleteness group might have difficulty with. And then, of course, no study is complete these days without having neuroimaging and functional MRI. And for those of you who are unfamiliar with that technique, most of you do know that you can go and have a CAT scan or an MRI, and it gives you a picture of what the brain looks like. So functional MRI is like that, only what we're doing there is we're trying to see what areas of the brain might be active in patients with certain symptoms versus other symptoms. So, for example, if you have someone close their eyes and then open them to look at a picture, you'll see the part of the brain that is involved in vision light up. And if you have them listen to a Beethoven symphony, or perhaps even to one of the current rock or punk bands, you will see their auditory cortex, which is involved in hearing, light up. So here, what we're really interested in is what pathways are engaged in these two different core features and how they might relate to the pathology. And if we're able to determine that these two groups have two different circuitries, then that helps us be able to think about how to target them either with different drugs or with different types of cognitive and behavioral therapies, or perhaps with different circuit-based innovations. So that's the basic structure of the grant that we started about 4 years ago. Now, in order to be able to interview all of these people and be able to have these expensive MRIs done, that's where the money actually is put to good use. And also, of course, we like to reward our patients who are helping us and helping others for their time, so they're paid for their time as they participate in these studies. Now, how about what have we found out so far in this study? So first of all, what I would say is that uh, there is a lot of crossover between these two subtypes. So even though they're quite independent, what we find is just like there are a lot of patients with obsessive compulsive disorder that also suffer from obsessive compulsive personality, so do many patients with harm avoidant tendencies suffer from maladaptive perfectionism. And so perhaps that's the first thing to say is that these two things seem to be related. My guess is that they will have some shared biologic features such as shared genetics, and that they will also have some features in common in terms of their brain circuitry. What we're also beginning to find is that there are certain areas of the brain that appear to be involved in patients with incompleteness that are not involved with patients who have harm avoidance. So those areas of the brain in the very front part, what's called the frontal pole, and in the lateral part of the front part of the brain, called the ventrolateral and dorsolateral prefrontal cortex. Those are regions that we know from many studies in neuroscience are involved in what we call cognitive control. And you might say that the patients with incompleteness have excessive planning, that they have excessive cognitive control, much as Freud sometimes talked about the patients who had strict superegos who were overly perfectionistic. Also, we know that there's an area of the brain in the middle front part that's involved in trying to make sure that we do things right. It's involved in something called error monitoring. So it's constantly looking to see if the actions that you take are effective in helping you complete the task that you started out to do. And those areas of the brain also appear to be abnormal in the patients with incompleteness, as opposed to the patients with harm avoidance who have abnormalities in parts of their brain that are more involved in emotion, as you might expect, anxiety, fear, things that you might have heard of, like the amygdala, or like the orbital frontal cortex. So we're beginning to define that there might be a different neurobiology between these two subtypes, which we hope in the long run is going to be able to help us understand where in these various circuits we might be able to make an intervention that will make a difference in treatment. Also, what I would say is that we're also learning more about how learning takes place in the brain and how in particular certain things are reinforced. And in obsessive compulsive disorder and in other anxiety disorders, we're particularly interested in the concept of what is called negative reinforcement. So everyone knows about positive reinforcement. It's what you give your kids when they're doing a great job. But in science, negative reinforcement is not what you might think it is, because it's not the opposite of positive reinforcement. Instead, it's instead it is a concept that if in fact you avoid something successfully, so let's say that you check the door every night for 10 times before going to bed, what happens is you wake up in the morning and you find that no one has broken into your house, and you say, thank God I locked the door. So you're reinforced for doing an action that prevents harm. And that's what we mean by negative reinforcement. So one of the things that happens in obsessive compulsive disorder is that because of the fact that you get into the habit of checking the door every night, you never find out that if you didn't check the door, that nothing bad would have happened. So really, there's kind of a vicious circle that occurs, that what starts out as an obsession followed by a compulsion to make sure nothing bad happens turns into a habit that, before you know it, is reinforced without your even being aware of it. And so you do it automatically. So we're also interested in being able to understand how this negative reinforcement occurs in the harm avoidant patients, and how we might be able to affect that with new types of treatments that are not only exposure-based, but employ cognitive and other types of things to help you be able to break habits. So that gives a overview, I would say, of some of the things that we've been engaged in this particular venue and this particular research project. And I hope that it gives you a little bit of insight into the types of questions that we're asking, and why it is in some ways that new treatments don't appear overnight. They're really dependent on our ability to be able to research them carefully in large numbers of patients, and to be able to make certain about the validity of the results before they're actually come into everyday practice. So Ryan, I think that's about what I have to say here. It's a little bit short, but hopefully that gave you the point.
Sounds good. I have a quick question for you actually about that. Do you have you noticed like an overlap where people experience both subtypes?
Yeah.
Because I noticed that a lot in clinical practice, like not on the research end, but I noticed like they have a person will have both, or one at one time you treat that, it gets better, and then the other one starts to show up, or they interact together where there's kind of this rigid rule following perfectionistic way to prevent harm. It's kind of interesting how sometimes they overlap, and sometimes I just get one, or sometimes I just get the other.
Right. So that's one of the things that I think we're really interested in pursuing. Once you get one grant, you're always thinking about the next one. And in fact, one of the things that have jumped out from the data is that there is a very significant overlap. Many patients who have significant harm avoidant tendencies also have some incompleteness, and vice versa. So you may have 20% on either end that look like almost pure incompleteness or pure harm avoidance, but it's the majority of patients that have a mixture of the two. And because there are probably shared genes and shared biology across some of this, some abnormalities and connections in one part of the frontal lobe, you wouldn't be surprised to see abnormalities and connections, let's say, in other parts of the frontal lobe. And there are definitely interactions that occur so that, patients, as you say, who are checkers in particular, let's say, who want to have things totally turned off. And it's not just the thing that has to do with their worry about harm avoidance. So they have kind of a mixture of both. I think that, that has some treatment implications because what we oftentimes see is you're able to affect the harm avoidance symptoms to a greater degree than the incompleteness symptoms, that from the exposure-based treatments, as well as the SRIs, we're oftentimes successfully treat some of the contamination and some of the somatic obsessions or the aggressive obsessions. But if they have that overlap of incompleteness, then incompleteness comes to the fore.
Mm.
And in fact, in the IOP at Butler, we're seeing a much higher proportion of patients coming in with incompleteness because, their other symptoms have been treated with things that are generally out there available in the community. And quite frankly, we don't have any really great treatments for these incompleteness symptoms at this point.
Hmm. Yeah, no, that makes sense. I noticed I struggle sometimes with doing exposures around incompleteness where, because you're getting people to do things like the wrong way, right? The way they don't really want to, but there's like that rigidity of like, but no, it should be that way. And that's a little bit harder where that insight window, I think, than with the harm avoidance or some of the
Yeah, so
irrational
like,
worries of treatment.
I mean, I think that we think that the incompleteness subtype is very close to OCPD, if you will.
Yeah.
And so, as you know, the distinction there is oftentimes the OCPD patients, they call their symptoms egosyntonic. So in some ways, they want it perfect. And so instead of having something like anxiety, which is very ego dystonic and something that disturbs the patient, they very much want to get rid of, you're kind of swimming upstream against something that feels like this is the way I want to do it. And because it's not, they don't describe it as having anxiety per se. They
Mm.
describe it as it has to feel right. And if you then tell them, well, you have to do it this other way, it's not exactly anxiety. It's more kind of a combination of distress and frustration that comes out.
Yeah.
And it doesn't habituate in quite the same way that, the classic patients with avoidance and anxiety do.
Yeah. No, that makes sense. All right. Well, thank you very much for presenting today. This is very helpful, and I'm sure people will really get a lot out of it.
Okay, well, I appreciate it. And, we certainly are open to people contacting us about the studies that are ongoing. Feel free to email me at Butler Hospital, and we're happy to reach out to you.
All right. Sounds good. Thanks so much.
Okay, thank you, Ryan.
All right. Bye bye.
Take care.